Yes, thank you so much, colleagues. As I've just mentioned, I'm Sandile Mahlangu. Thank you so much. I'm seeing our colleagues and friends from India. I can see Anita Devi there. I hope joining with the team as far as India is concerned. Thank you so much for us to join. We are dealing with one part of criticality in palliative care. We are looking at how best we can support our loved ones and how we can meet their needs holistically. And last session, we were looking at how we can manipulate or use the biopsychosocial spiritual model to help us get comprehensive information and engage with our patients, as we are trying in palliative care by all means not to leave anyone or any aspect of the patient unattended. Patients, we are understanding now that as the patient is a whole being with spiritual, psychosocial, and physical being, you find that one aspect of the patient, if not attended to, has an impact to the other. So then that one means that whether I'm a social worker, whether I'm a clinical psychologist, whether I'm a doctor or a nurse, I am a dietitian, or any of the IDT members that we were once discussing on the 5th of June. So it is very important that whenever we have different ways of assessment, but the biopsychosocial model will align our assessment and help us get more data that we need to help us prepare and work together with the plan with the patient in terms of achieving the goals of care. So with that in mind, we are still to look at more interesting topics, but then we introduced last session that today we will be revisiting how to break bad news well. 2022, if not mistaken, when we were starting the program, we did touch on communications in palliative care, and breaking bad news was part of that package or module. So it is available in our YouTube channel. If you go to YouTube, you can find it, Eswatini palliative care session, so you can find it there. So today we will be revisiting it. The reason we tried to say, no, we need to redo this module or this aspect of psychosocial support is because this is the beginning of the journey of palliative care in most of the time. And you find that the journey of palliative care or the patient as they journey through the trajectory or with the condition for the patient and the family, you find that most of the time we have to break bad news now and again, now and again, now and again, just from diagnosis. For example, we'll be breaking bad news that medical medicines out of stock. We'll be breaking news on treatment failures or a lack of treatment alternatives. We'll be breaking bad news on end of life. We'll be breaking bad news on death. We'll be breaking bad news on a lot of things that are bad news. So we say that, while we have now been equipped on using the biopsychosocial, can we be equipped again on how to deal with how to break bad news? As clinicians, one of the duties that we have is to ensure to break bad news well and help our patient cope well. And under palliative care, breaking bad news, sometimes well-treated aspect under palliative care psychiatry. I'm grateful to have attended training on that. But then today we are going to do it together. So we have our social work student from Botswana who will be helping us today to unpack this. This is people from the field and from the theoretical practice. So they have the fresh understanding of what is East. So we are hoping to get more knowledge and understanding. And in the house today, I'm joined by a team of social workers. Let me show you here. There are a full page of them. That one is our chief social worker, Messi Shabanu. And then we have praise. Then we have which one? Tebanda. I almost say the opposite one. Tema Church. So at least now I've said correct. So we have the team of social workers here, whom I believe they will be able to even to share with us their experiences, and also the team, as we are also going to be free to do so as team members, share our experiences in breaking bad news. On that note, you are free to introduce yourself and the one you are joining with by writing your name here on chat. May I request that you do so? You just list your members on chat, and if we hope if you have joined via a gadget or you are a group, ensure that we are all registered as a group members. If you have not yet accessed the registration link, you can WhatsApp me or email me, and then we will be able to respond to share with you the registration link so you can share with your colleagues. You can respond to the email that usually comes with your reminder for sessions, and then you can get your response from there, and we'll be able to share the link with you. But I will try, as the session goes on, to share the registration link in case you will want to share it with your colleagues, so you can copy it and share with them so they can be part of this session. Thank you so much. So for this time today, we are going to have in-depth discussion on breaking bad news, as this is one of the challenging issues that we are facing in palliative care. So we will have more discussion on it. And then in the next session, we will have a case together with, we will have a case presentation together with, what we call this, together with the didactic presentation. So in our next session, so as I've mentioned, we'll alternate them so that we can have moments where we'll have time to discuss the issues. May I give this opportunity to Simpiwe Mavuso, our guest lecturer today, who is going to help us with the presentations for today. How about you, Mavuso?
Good afternoon, team. I am Sylvia Mavuso, and I'll be taking you through today on the breaking of bad news. Breaking bad news. What are bad news? Bad news can be defined as any news that drastically and negatively alters the patient's view on his or her future, or if any information that is negative or unpleasant that will alter the views of his or her future. And bad news can impact various things in a patient. It can be emotionally and psychologically. And delivering such news is sensitive and also crucial. Breaking negative news requires a number of things. You have to be patient and refine So, sorry, breaking bread news requires a lot. It requires patience and refined communication skills. You have to be honest, have empathy, and be sensitive toward the patient. It also, you must also be approachable, yes, with empathy for all parties involved, must and it also be presented based on the access level of the patient, which will be understanding, compliance, and the wishes for disclosure. It is very important to break bad news. And this is because it improves the patient's compliance and adherence, emotional health, informed decision-making, and sense of control. Certification, including perception of inclusion and competency. This is because breaking bad news has to have clarity and transparency to maintain trust and transparent relationship between the patient, to avoid misunderstanding and rumors from spreading. Also, breaking bad news is important because it improves the ability of clinicians to firstly formulate more accurate care and treatment plans, have less work-related stress, and reduce burnout. Excuse me.
Apologies, our gadget is misbehaving here. So. What is
Sorry about that. I was talking about the importance of breaking news, that also it is important because it improves the ability of the clinicians to formulate a more accurate care and treatment plan, and also have less work-related stress and reduce burnout. Common scenarios and tasks when breaking bad news. Firstly, you have to give diagnosis or the bad news, communicate prognosis, explain complex medical info, clarify on the goals, determine advanced directives, talking about dying, loss, and grief, and also pronouncing the death. Why is breaking bad news so difficult? It is because there's feeling of incompetence, communication. You don't know what to expect from the client emotionally. It can be their reaction, which can include anger, sadness, or shock. Also, it is difficult because you are fearing that you are in fear of being blamed, failing, and you may have this feeling that you have failed you may have this feeling that you have failed the patient by not curing them. Also feeling embarrassed and you don't have enough time. Sorry. Feeling powerless to handle emotional distress. This may be painful and unresolved issues of loss. How not to break bad news. Talking jargon and statistics. You may say things like, oh, how long have I got to live, doctor? And the doctor may say, well, there is a 67% 5-year survival rate among patients like you with a stage 1 disease. The please don't tell scenario, the hit and run approach. For example, the doctor may say, the MRI scan shows that the tumor has spread to the lungs. We will refer you to hospice and they would look after you. The velvet covered hand grenade approach. For example, where the doctor can say there is a bit of lesion on the X-ray, and the patient would not know what that means, and ask what does that mean? And the doctor may say, oh, it will be all right. I'll keep an eye on you from time to time, so we won't be abandoning you. Patient says, will it be okay if I go on holidays over Christmas? And the doctor will say, it would be the best to stay near home just in case. And this is not a good way of breaking bad news, because the patient is unaware of what's happening. You have to use simpler words or simpler communication for them to understand on what's really happening and not cover the truth. And there's also some major no-nos, things you shouldn't say to the patient when you have to break bad news. For example, there are many others with the same problem. There are others worse off than you. Be positive and look on the bright side. We all have to die someday. If you just stop these habits and eat healthy and take your medication, you'll be fine. Don't worry, everything is going to be okay. These are things that you should not be saying to the patients. You have to tell them the truth, be transparent on what's happening, and not give them hope if there's none. And there's difficult questions to ask clients. I mean, patients can ask when you are breaking bad news, and it's difficult to answer. For example, how do you answer the question saying, am I dying? Is it cancer? Do I have AIDS? Ask questions about the question. Ask questions about the need for the information. Be the patient's advocate. These are some difficult questions that patients ask and need to be answered. So I may kindly ask our team to help here on how can you answer some of these questions. Am I dying? Is it cancer? Do I have AIDS? Anyone willing to help?
Yeah, maybe like others, they'll say how best to do this. But these are one of the immediate responses normally one will get from the clients whenever you are breaking any bad news, even if this may not be the exact question, but these are one of the patient's questions they usually ask. Will that mean this is the end of my life? So I think the best strategy is to not jump to the gun and shoot to the patient the answer you think is what the patient knows. My experience, I've learned that normally when clients ask, they already know the answer. So good communication skills will pull you out of that challenge. As Mafuso has already said that sometimes we have challenges to break bad news because we fear we will fail the patient. We will fear the patient will hate us. Because if then the patient can say, am I dying? Do I have to lie and say you are not dying? If you are dying, I have to say it. But the issue is, it's a harm of what I hope would be very answered before the session ended. But these three tactics, I think, are the best way to respond to such questions. That you need to ask the question about the question. For example, is this cancer? One of the questions that I could ask is, what makes you think it's cancer? What do you know about cancer? So I'm just making example. This is when the patient will tell you things, and then the breaking bad news issue will then be completed without hurting the patients. Sometimes you will ask the question, maybe the patient will need to know more information about it. So it's very important to ask the patient do you need more information about something? Because some patients will say, am I dying? Sometimes you'll find that they know, but then they need to understand about the things they need to check on if the client is dying, especially when the relatives are saying that their loved ones might not be okay. So most of the time, I think that's what is very important. And maybe the last one is here mentioned that becoming the patient advocate. You know, sometimes in the clinical setup or even at family or community level, you will find that patients will have these questions, but then there will be this over-bullying. I don't know what I would say, bullying or what. They will be overriding or turning down the patient. When the patient says, am I dying? And the relatives know the fact that the patient is dying, but then they don't want the truth to be known to the patient. Then they will say, do not dare tell the patient. Then that's very important. Then that's when begin to be the patient advocate and advocating for the patient so that the truth should be told, but in a dignified and healing way. So that even if those emotions, psychological emotions or emotions are triggered, should be the normal grief and should be well managed for the patient to cope well. So I think that's one of the things I can say from my experience have helped me to deal with some of the difficult questions that I have to respond to. But it's not easy. Sometimes the patient might not appreciate you on that day, but when reality comes, whatever you discuss on the patient on that day helps the patient. Actually, they are able to make informed decisions sometimes knowing that this is a real issue, other than sugarcoating it and running away from it. I don't know if anyone else may like to add on dealing with it.
Thank you so much, Mr. Mashamo. That is how we can deal with those difficult questions that patients come and ask. We'll move on to the listening models. There are different types of listening models, which are, for example, there's the nurse model, ask and tell model, and spikes model. I'll be using the spikes model because it works best when breaking down bad news. This model is by Robert Bachman. The spikes model is used for breaking down bad news. I'll be breaking down the spikes and defining what each letter means. The S from the spike means getting started. You have to get a quiet place or a space where the patient is comfortable and there will be no disturbance for you to break down the news to the patient. Secondly, the P in the spikes model stands for perception, or finding out how much the patient knows about the disease or the diagnosis. Thirdly, the I stands for invitation, or finding out on how much the patient wants to know about their illness. The K stands for knowledge and sharing information. You should give the patients clear information. You should be transparent and tell them the truth on the outcomes that will be happening, and also listen on what they want to share. The E stands for empathy, or responding to the patient's feeling. How do you respond? If the patient is sad, angry, you have to respond to that with empathy. And lastly, the S stands for strategy, or planning on planning and follow through. What will be the next move? How will you help the patient? How does the patient feel about what you've just told her, and what is the way forward? The setting of getting started. This is the most crucial step. This is the most crucial step in the spikes model. Yeah, what you have to do is set time aside, be prepared, and you should also being prepared you should also know your limits. There are things you cannot say to the patient because you don't know how he or she might take it. Also, this should happen in person. You have to be open and honest to the patient. Minimize interruptions. Get the physical setting right for the patient to be relaxed and comfortable, for him or her to ask anything and for you to help them. And lastly is setting down. You should also consider who should be there, either the family members, if the patient is comfortable with people being there, but if not, you have to respect their wishes, and also you have to establish a rapport. The perception of finding out on how much the patient knows. You have to obtain an impression of what the patient already knows or understand about their illness and seriousness. You have to use open questions. For example, how, where, when, what. I was wondering, and you should explain to that. You have to avoid closed questions, like reply yes or no. The why question may appear loaded or threatening, so you have to avoid it. For example, of some of those questions may be, what the doctors have told you. Have you been worried about your symptoms? It would help me to know what you understand about your illness. How did it all start? What is important about this for you? That is the invitation of finding out on how much the patient wants to know. Real issue is not do you want to know, but at what level do you want to know what's going on? Omitting this leaves subsequent parts of the interview on a delicate and insecure ground. These are the things you don't have to omit. Does the patient want to know all the details? How much info do they hear or remember? What about denial? Are they in denial of what's happening to them? Fourthly is the knowledge or sharing the information with the patient. You have to start by repeating the words used by the patient, reinforce those parts they say are correct, give a warning shot. You were right, for example, like when saying, you were right when you said it is looking more serious than you thought at first. Give information in small chunks, use narrative events, ask permission to discuss issues, be clear and simple, use kind words and avoid jargon and medical speak for the clients to understand, because some words that you can use may be hard for the client to understand. Proceed at patient's pace and reinforce information frequently. Use diagrams and written messages. And also you should know when to stop sharing the information with the patient. The fifth step is the empathy or responding to the patient's feelings. You have to identify and acknowledge the patient's reaction. Help the patient to name their feelings. How does this leave you feeling at the moment? It seems to me that you are feeling like this. You should use empathy. You have to stay calm and allow the patient to think. Use silence. And the last step in the SPICE model is the strategy or planning and follow through. Firstly, your patient may at this stage be feeling overwhelmed, bewildered, or disorganized without hope. Enumerate problems in a list. Make a plan and explain it. giving patients options where appropriate. Is it okay? Am I getting this right? Be available for the patient. When I say available for the patients, I mean for further explanations, be there for them. You can be there when she wants to disclose the matter to the relative, be there for support. Expression of empathy or non-verbal. How you express your empathy to the patient. Eye contact. You sit down, face the patient, open body posture, lean towards the patient, and relax without tension for the patients to be comfortable. Also, there is touch, cultural cues, and the verbal ways to express empathy are naming, you seem upset, understanding, for example, this must be hard for you, respecting, I am so impressed, supporting, our team will be there, exploring, tell me more about how you feel. Expressing empathy, helpful tips is active listening, ask, tell, helpful phrases. The helpful phrases can be, I wish things were different, tell me more, goal setting, and also reframing. Thank you. That is all I had for breaking down.
Thank you. Thank you, Mavuso, for your presentation. May I give this opportunity to you, colleagues, to share what you have as far as bad news, but on a summary, the bad news are any news that may evoke negative emotions, even though they have the potential to evoke negative emotions, and even though they are bad as they are characterized, but they must be broken. And good communication as a pillar of palliative care can be a good tool for us all to break bad news well. You know, the problem is not the news being broken, it's the issue of how were the news broken. I saw another study done in Ethiopia. I shared with my team, if not mistaken, some weeks back, that clients, the study was a qualitative study, and the experience of these clients when it comes to bad news. Some were not given the chance to reflect on their conditions. Some, they fell ahead and felt like nobody take care on what is happening. So, yeah. So the issue is not that the news are broken, but the issue how. I remember at some point we had a case at Hospice that was referred to us, and we were supposed to do a home visit. Unfortunately, we found that this client had cancer, and the bad news were broken, but the patient's side was not taken care of in such a way that this patient was repulsive of anything that has to do with healthcare. So it took us some time to clear the challenge of the head the patient has gone through. Unfortunately, before we could even go then further beyond the head, that was caused by the process of breaking bad news that was provided. The patient died. That was painful because we couldn't go any further until we deal with the healing from the improperly broken bad news. So that's why we are bringing even it today to say, guys, this is one of the things. I don't know if you have ever broken bad news to anyone, colleagues. Maybe we can share our experiences in a few minutes. What went well with you and what didn't work with you? Was it an easy thing? What did you get from it? Maybe we can share and we can learn from what you can share with us. If anything we have to share with us, we can appreciate that. Yes, Mercy.
Thank you, Mr. Machao, and thank you, Simple, for the lovely presentation. I think what I got from the presentation is that in healthcare or in palliative care, there is no way of avoiding issues of breaking bad news. As it has been mentioned, from diagnosis till end of life, there's always a point where you're going to break bad news to your client. I think for us as a palliative care team, mostly as the social worker, it happens that we usually find that the bad news have been broken to the client, and sometimes we have to deal with the aftermath, like Mr. Masham has just said. Which is some of the clients, yes, the bad news have been broken, but this person. And when we do the home visit, one of the first things that we find ourselves doing is actually trying to deal with the issues of the hospital and actually, I don't know if I'm putting it okay, if I'm saying apologize to the client, because we are healthcare workers, then the client tends to with that category. Like those others who have probably haven't treated him or her well. So it would just to encourage all colleagues, we should take the issue of breaking bad news seriously, because it is the one thing that will help us to be able to move well nalo client throughout the trajectory of the disease. That helps us in issues of adherence to treatment. And see if the communication wasn't a smooth one, the client might be reluctant on a number of things, making it difficult for anyone that has to work with that particular client. Thank you.
Thank you, Mercy. Anyone, colleagues who may share experience on bad news? Even they're bad, but they need to be broken. You know, yes. If anyone wants to share, another thing I can say is that communication is a skill that is learnable. If there's something like that, you can learn, and we practice daily, and we get better and better daily. So, yeah. Anyone who would like to share experience? Have you ever broken a bad news? In our context, I don't know in India where Anita or David are there, if they have any scenarios. What I understand is that whether I'm in palliative care, I'm in oncology, I'm in special care or ICU, I'm in inpatient ward, I'm in OPD, I'm working in MCH or ANC departments, where I'm working in the art department, wherever there is a person faced with a life-limiting or life-threatening condition. As clinicians, we have at some point have to break bad news. From the simplest maybe to say, I don't have Panadol today, to the deepest that That is by the door. So I don't know anyone who wants to share. Yeah, but that's what we are saying. So another issue that I can say in your preparation for bad news, always be ready. Don't go to break bad news not prepared. Go and learn about the diagnosis. Get to your team. Do you remember the interdisciplinary team? Get to your team. Get their ideas. If in terms of linkages, resources available, the diagnosis and prognosis. Get to know, be ready. Prepare yourself, get all medical records concerning the patient, know the history about the patient. Then you can go for a time for breaking bad news. And most of the time, if it's on diagnosis, breaking the diagnosis about the limit or the life-limiting condition, you will need maybe to have those investigation results that have been done, and then be ready with them, understand them. If you can't understand them, get experts to interpret them for you so that you are ready and understand what is happening. But most of the time, clients are aware there's something wrong. And there are things I've also mentioned during the presentation that we need to use. There are many ways of breaking the ice or opening the statement. The first one, what have you been experiencing for the past days? How have you been feeling? If it's a nurse or another person other than the one who conducted the result, or a certain doctor, what were you been told about your condition? What is it? What do you understand is happening? You know, there are many things we can ask. If it's families, what do we understand about the condition of our loved one at this point in time? Other than saying, why do you think is happening? So we need to use the what, how have you been feeling in the past few days? What have you been? So these are the open-ended questions that helps the patient to express themselves. Even ask them, do you have any concerns? Is there any information you may need to know? How much information you feel you know? Let's just cut it. The clients may never differentiate on how much they want, but my experience is they are able to tell you how much I want to know and how much I don't want to know. And that one helps you to know your limits and when to stop and when to go. And one of the things I may include is that we need to respect patients' emotions. You know, I don't think it can be good to continue breaking bad news while your patient is continuing crying. You know, your patient is crying and you are continuing, right? There is no way. You need to allow the patient respond to the emotions. Sometimes it's not good to break bad news to already a person with distorted emotions or psychological status, because you might cripple the patient further. So that's why it's very important to assess the patient. How are you doing today? So welcoming the patient, getting to know the patient better even before we go to, even if I'm going to declare HIV results that were taken to laboratory or something, then ask the patient, how have you been doing? How was your day? So you can understand the situation of the patient and be ready to support them. And whenever you have time to break bad news, prepare for those meetings. Let the family be aware. We will be discussing this in our next meeting. If it was diagnosing, you in date so and so, we will be discussing your diagnosis. Then prepare whom would you like to come with. You understand those things. If it's me visiting the patient at home, the normal way is to prepare the family for those times. You know, today, because there were these concerns you are having, may we schedule for a meeting that will have time to discuss this? And then the patient will say, or the client will say, yes, we can allocate that time for us to discuss that. And then you ask the patient, whom do you like to be present? And then they tell you, then you schedule that meeting for breaking bad news or discussing those difficult questions or those difficult decisions to be made. So that's how it is going. Then you will follow that. I'm seeing someone writing there. I'm reminded of our last session where we had a case of this lady who was told that she has to stop chemo, and no one explained why that is. So it is also crucial that one explores the client knowledge and understands about their condition, as this may help you tailor responses to the client based on their level of awareness and readiness. This also talks to collaborating with the interdisciplinary team involved to care that the information provided is consistent to avoid confusion of the client side. Yes, yes. That's why preparation is very key. Actually, I'm thinking of a doctor saying we are stopping chemo, and the nurse saying I'm sketching you for chemo. You know, that would be a client stopped from treatment is a bad news, but then if the team is not in collaboration, blunder will happen. Even when withdrawal of certain medications, another team will do that. It's a problem. Okay. Yes, anyone else? If there's none, thank you so much, Mafuso. Mr. Pumai, I Obego spoke to that. Have you ever broken any bad news, and what has been your experience if you have? Is Mr. Pumai there? Mr. Pumai. He's not here. Mr. Msisi.
Yes, Mr. Masha.
Yes, yes. We are asking you if you have broken any bad news yet, and what has been your experience with it?
Okay, Mr. Masang. I think I've broke some bad news where client was not aware of the diagnosis, and I have to clarify and explain to him about the condition. Yeah, it was not an easy experience. Yeah.
All right. Zwani, from our RFM team members. Have you ever had a point in time where you have to break bad news? Or your social workers there? I know you have your team with you. Have you ever had an encounter where you were supposed to break some bad news to your?
Hi, everyone.
Yes.
I think in palliative care is great, bad news every day.
Yeah.
But our challenge is that as we at RFM, we are a outpatient department,
Mhm.
and they refer patients from other departments like MCH, the gynae clinic, OPD, and you find that the doctors there just write on the file, go to palliative care without even explaining the diagnosis to the patient. So when they come here, it just becomes a lot.
Mm,
Thank you.
thank you. Today I'm missing our Manzin oncology team, but Anita David, you know, have you ever had such experiences in your country where you're supposed to break bad news? Maybe, are you there? All right, thank you so much, colleagues, for joining. I think we can all agree that breaking bad news is not an easy task. Even if they're bad, they need to be broken with humility and respect of one's emotions, confidentiality. And the last thing that I liked about breaking bad news is that when you are done with breaking the bad news, don't leave the patient hopeless. There must be a strategy or a way forward. As Mavuso said, that maybe then we will be with you, we will support you, and we'll link you. Another thing that maybe she never mentioned is that after the patient has given you the right to break the bad news, then now you are sharing the information. It is very important to use, we say that in breaking bad news, silence. Silence is golden, you know. Let me make an example. I'm breaking the bad news, and then now I've got the permission to go on now and give the patient, I've given the warning shot. I'm sorry. Today I have bad news for you. You know, whether maybe there's a prognosis that is poor, and the patient is hoping for the best thing, but yet today I'm bringing some bad news of a poor prognosis that is going to happen. It's going to happen. Then I will gonna then say, you know what? Today I'm sorry. I have bad news for you. Or when I've asked the patient, how do you feel? And how is your day going? How do you see your condition? And then maybe the patient say, you know what, I'm getting worse every day, and I can tell that one time I will die. And then I will say, I'm sorry to say, I don't have a different answer today than what you've already said. Or I say, I'm sorry for that. I don't have a different view. So it's very important to give the warning shot, then give the news. I'm sorry to have bad news for you. The results show that you have cervical cancer, stage 4. And then silent mode. Allow the patient to express the emotions, allow the patient to react, and then take it from there and responding to the patient's emotions as they are showing it up. It helps. Other than saying you have cervical, you remember that don't do it, the rush hour. You have the MRI schedule that we have cancer, and we will take you for this and chemo, and I will meet you next week. But the patient has not even digested the first thing that I have. So we need to allow some moment of silence, and then we continue with the process and responding to the patient. Some will cry, some will ask questions, some will be just angry at you and want to fight with you from there. So yeah, they will, Kubler-Ross reaction comes in different forms at that moment. Some will fight, some will fly. So then, but we have to respond to what the patient is. So I just wanted to emphasize on the issue of silence, that once you have broken the news, silence. And don't deliver everything on one day. Give the time the patient, schedule for another visit. You may say to the patient, you know, today may you go home, think about what we have talked about, and then next time when we come back, we will be discussing a way forward. So then you schedule a day to come back and then plan on how best we can support you. Otherwise, I and my team and other people, you may name them, we will be available to support you. So then you give them that time to go and digest. When they come back, then you come with the plan going forward. I don't know if I'm leaving something behind. Otherwise, that's what we can share on breaking bad news. So it's very important. Even in our personal lives, you know, it's very important that we understand how to break bad news, because that one is very important. How to tell your children, today you will be eating tomato and bread alone. There's no food. How to tell your children you are not gonna pay school fees because you are not having enough money these days. How are you going to tell your children or your workers you are not gonna get your salary month end? You know, so you know those things that are very important to understand. So the spikes model helps us not only in breaking medical bad news, even life social related bad news. How to break away from a relationship. You know, relationships, they have harmony. You love one another, it's nice. But then if it has to end, sometimes using spikes is a good way of breaking it nicely, other than just dropping the bomb and leave it that way. But that's how we can do. Then what is this one is taking us? We are now going for another session that we will have on the 17th of July, 2024 at 1 p.m. South African Standard Time, 17 July, where we will be looking at facilitating a family meeting. You know, it's not an easy thing to do, but under psychosocial support, we will be looking how best we can facilitate a family meeting. And also this one will be a redo course, so we'll be doing it again. So we are inviting you again to our session, where we will be looking now at how can I facilitate a family meeting and end up achieving the goal of the family meeting and helping ensure that I'm doing it well and successfully. So we will be looking at that topic. Thank you so much for joining. Have a great day. The session video will be available on YouTube in hours from now. To be running premium, and then the presentation will be available in our iEco platform. You can access it at any time. If you have not downloaded yet the iEco app, I can encourage you to do so. It helps you to join and access any materials as easy as possible. And once you are registered, as I've shared the link here, please do so. And yeah, and it will help you us know who is where, and it will help you to be part of the member. It helps you to have access to the materials. And also please fill in the feedback form that I've already shared. Before leaving, click it and share your feedback with us so we can improve the program. Remember that each session carries 1.5 points. For those who did completed the last module, we have released, we hope they've received their certificates. And also in this module, We will also have certificates for those who may need those hours to renew their licenses, whatever they are. We are able to release those ones, but you need to fill in the post and the pre and post test as we have shared it with you. Thank you so much. Have a great day. See you 17 July. All right.